The Epilepsy Foundation is pleased to share with you an educational webinar, Epilepsy and Cognition. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. Today's webinar is brought to you with support from NeuroPace. My name is Dr. Elaine Kiriakopoulos, and I would like to extend a warm welcome to everyone who has joined us today. The Epilepsy Foundation is working to provide information and education that serves the spectrum of individuals and families impacted by epilepsy. I'd like to review with you the format for today's webinar. Throughout the presentation, all phone lines will be muted. However, we'd like to encourage everyone to submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel and click Send. We will read your questions aloud and address them during the question and answer portion of the webinar. Please keep your questions general in nature, as the webinar is intended for educational purposes. This webinar does not take the place of individual medical advice. The webinar will be recorded and available for viewing and listening on epilepsy.com. Today's learning will focus on cognition in epilepsy. The word cognition refers to our ability to learn and to understand. It encompasses thinking, knowing, remembering, judging, and problem solving. Under the umbrella of cognition, we also consider higher level functions of the brain that include language function, imagination, perceptions, and planning. We are so fortunate to have with us today to guide our learning and to help us better understand the relationship between epilepsy and cognition, Dr. Bruce Herman. I'm honored to introduce you to Dr. Herman. Dr. Herman is Professor Emeritus in the Department of Neurology, University of Wisconsin, School of Medicine and Public Health. His clinical and research career has been devoted to understanding the effects of epilepsy and epilepsy surgery on cognition and behavior in children and adults. He has served as chairman for the Professional Advisory Board of the Neuropsychology Task Force for the International League Against Epilepsy and as chairman of the Professional Advisory Board for the Epilepsy Foundation of America. He's been a recipient of the Service Award from the American Epilepsy Society and the Distinguished Lifetime Contribution to Neuropsychology Award from the National Academy of Neuropsychology. He has published over 300 peer-reviewed papers and served on multiple scientific journal editorial boards, including Epilepsia and Epilepsy Research, and is currently the associate editor for the journal Epilepsy and Behavior. Dr. Herman is currently a principal investigator on a study, Brain Aging in Persons with Childhood Onset Epilepsy, a population-based investigation. The goal of this study is to examine long-term, 50-year outcomes of cognition, brain structure, and amyloid deposition in persons with childhood onset epilepsies. Dr. Herman has been a steadfast supporter of the Epilepsy Foundation, and we are so thankful for his making time to be here with us today. Welcome, Dr. Herman.
Thanks so much, Elaine, and it's an honor to be here and to be able to speak about this topic with folks who are on the phone. Can I have the next slide, please? There we go. So what I'll do in the next 45 minutes is, first of all, make some sense of memory and cognitive complaints, which are very common concerns of the general population and people with epilepsy in particular. We'll talk about assessing memory and cognition, how it's done in neuropsychological evaluation, review some specific details of cognition and memory in epilepsy in both adults and children, and then importantly, say a few words about maintaining cognitive health. Next slide. There we go. So cognitive complaints are common in people with epilepsy. The cognitive complaints, subjective memory concerns are very prominent, and people with epilepsy have more subjective memory problems compared to controls, as you see here, 54 versus 23%. And it's complicated by a wide variety of factors, as we'll see, including depression. Next slide. So let's make sense of memory complaints. Next slide, please. We at the University of Wisconsin, we have a very busy clinical neuropsychology service. And we see patients with epilepsy, but also patients with a variety of other medical conditions. We're the service for the medical hospital and university. And one of the first steps that we take in the process when individuals are referred to us is have a conversation about what they're concerned about and try to figure out what those concerns mean. Next slide, please. So it's very interesting. The referral may be subjective memory complaints. And when we say to the patient, so tell me what you mean by memory complaints, what sorts of difficulties are you having? We will get a very wide range of concerns across people. So for some individuals, I say, well, I'm always misplacing things around the house. Someone else may say, I just can't think of words or names of individuals I know when I'm talking. Others will say, well, my kids tell me I repeat myself, I'm not aware of it. Common complaint is I read a page and I can't recall what I just read. Or I'm driving and I can't remember where I'm going. I can't remember names after I'm introduced, very common complaint. And I may go to another room and forget why I went there. So these are actually quite diverse concerns that are presented to us when the patients will present at the clinic. Next slide, please. So I'll give you a way that we think about this. And in order to actually make a memory, a few things have to happen. And this will make sense as we go along. But to make a memory, first of all, whatever it is to be remembered has to get in your head, so to speak. So there has to be registration. You have to be focused enough for that information to get into your neural systems. And then your brain needs to do something over which you have little control, which is the consolidation process. Something needs to make that memory, that idea, that thing you want to recall stick. And then finally, later on, you have to pull it out. So if you're watching a movie, you have to pay attention. It's got to get in there. Your brain has to do something. And then if someone asks you a question about the movie later on, you have to pull the answer out from your memory bank, so to speak. Next slide. So a lot of the complaints we took a look at can be sourced to registration and attention failures, so-called input problems. So someone who has an input problem might say, well, I just read this page and I have no idea what I just read. I think that happens to all of us. Or I have a conversation and can't recall what was just said. I'm introduced to someone, can't recall their name, and I go to a room, why am I there? So these are issues where things aren't fully processed to be remembered later on. Next slide. Really irritating and a common complaint are these so-called retrieval failures. These are output problems. And these involve words and speech, names of individuals that are well known. You may not be able to think of an individual's name, but you know where they work, where they live, what kind of car they drive, but you just can't think of their name. It's really irritating. Sometimes there's difficulty pulling factual information out of your head real quick. And a good example is if you ever watch Jeopardy, those are people who are quite bright for sure. They have a wide range of factual information, but they can also pull it out of their heads just in a dime. So if you happen to be watching Jeopardy, you might know the answer, but it'll just take you a little bit longer to reach that. And in those circumstances, recall is generally facilitated by giving a few hints. So it's not forgotten, it's just sort of an access problem. So those are output problems. And next slide. And for us in neuropsychology, we're really concerned about what are called this consolidation problem, where someone really does attend, it gets into their head, but there's a failure of the process of consolidation, of gluing that memory into memory, and no amount of cueing can get it out, so it's actually forgotten. So in those cases, there can be poor recall or increased forgetting of conversations that is really a believable failure of consolidation. Poor recall of events and activities, poor recall despite cueing and hints, and in the worst possible case, where every day is a new day and there's no recollection for what happened the day before, or even the morning before, so to speak. Next slide. Now, epilepsy is not the only thing that can affect these input, consolidation, and output issues. Actually, a variety of medical disorders and their treatment can affect registration or input, retrieval, and storage. Next slide. And this is important because, we now know that epilepsy has a variety of comorbidities. Some people with epilepsy are anxious, some have mood disorders, some have sleep problems, some have ADHD. And we know in the general population, if you go to an anxiety clinic or a depression clinic, that individuals there will have memory complaints and problems with memory performance. And so if you add that on top of epilepsy, that can contribute to further memory difficulties. Sleep disorders are very common. Folks are tired and fatigued during the day, drowsy, and can't focus and pay attention. And if you're anxious, you're usually a little bit tangled up in your head, worrying about things, concerned about things. Individuals who have chronic pain of various types, chronic pain can be just wearing and distracting, and the medications can be affect arousal and attention. And of course, ADHD is a commonly occurring condition, and there are problems with encoding registration there. So if you have problems inputting information, you're just not going to remember it later. So a lot of complaints about memory are due to this encoding, registration, or input issues. Next slide. Retrieval difficulties, which are among the higher annoying sorts of difficulties, can be seen in normal aging, so it's part and parcel of normal aging. Can be seen in other medical conditions such as multiple sclerosis, or in conditions such as cerebrovascular disease and stroke, where the information is in there, but folks just cannot pull it out rapidly or efficiently. Next slide. And the worrisome are the consolidation and storage problems, where someone pays attention, it gets into their head, but the biological processes that make information stick are just not working, and so the information disappears fairly quickly. And this can be seen in temporal lobe epilepsy. It can be seen in a variety of other conditions that are pretty severe, such as autoimmune encephalitis, preclinical Alzheimer's disease or Alzheimer's disease, focal stroke. Those all can affect consolidation and storage. Next slide. So from a clinical perspective, someone shows up at the clinic and they have concerns about memory issues. It's clear that memory and cognitive concerns and complaints are really quite common. And if you have or you do undergo a neuropsychological evaluation in the future, there'll be a very careful clinical interview that will be helpful in targeting exactly what the underlying issues appear to be. Those complaints will then be referable to various cognitive systems or processes. And then objective cognitive assessment can be very helpful in characterizing the nature of the problem as well. And it's important to, when you think about these difficulties, think about the associated comorbidities of epilepsy that may be playing a role in contributing to cognitive concerns. Next slide. So the other issue, which is of great importance, is how cognition changes with development and aging. Next slide. The world population is aging. You've probably heard this if you watch TV. There's a lot of concern about the aging of the world populations and the increased frequency of age-related diseases, including neurological diseases, epilepsy, and Alzheimer's disease in older individuals. And this just shows our state of Wisconsin. On the left is the percentage of persons age 65 plus in 2005 and the projections for 2035. And the bluer you get in that graph, the higher the proportions of people over 65. So Aging is happening worldwide. It's happening here in Wisconsin. It's happening in our county. And it's an important fact. And it does impact cognitive complaints and concerns and actual cognitive performance. Next slide. So with normal aging, there can be a variety of cognitive changes, and I'll show you some specific findings in just a moment. But with age, some cognitive abilities remain stable or even improve with normal aging, and some cognitive abilities clearly decline with aging. There's no question about it. It's a normal process, even though it's a decline over time. Next slide. So here are some abilities that remain quite stable over time. This comes from normative base of some of our major neuropsychological tests. So on the bottom axis, you can see chronological age, and then plotted is performance in terms of Z-scores across the decades. And some abilities remain quite stable into the 70s and beyond, such as your vocabulary, your word knowledge, your fund of information about the world. Those are actually called crystallized abilities. They're pretty solid, they're stable, and they remain so over time. Next slide. In contrast, some things progressively drop over the decades, such as how fast you can do things, processing speed, cognitive speed, how fast you can solve a problem in your head. You can still solve the problem, you're just not as quick. You can do things quickly, just not as quickly. And as you can see in this slide, processing speed starts to decline in the 20s and 30s, and it's a linear downward trend. So it's something that just happens normally. And people will say, well, I just can't do things as quickly as I used to do. And it could be that that is totally appropriate for chronological age, and it may not be, and we can figure that one out. But what about memory? Next slide. Memory shows a slower downward path over the decades. So there is decline in memory, and again, you can see it becomes evident in the 20s, 30s, 40s, and progresses on. And there can be different trajectories depending on one's circumstances. That can be a steeper slope given certain conditions, which we'll talk about. It can be a little bit flatter curve, but there can be downward progression in short-term memory function over the decades, which is noticeable to the patient, the person, but may not be abnormal, which is an important thing to remember. Next slide. And this shows the same thing in a different slide, and those bars that are going across that are not dropping are language-based abilities called world knowledge. And then the downgoing bars are speed of processing, working memory, long-term memory, just as we discussed. Again, another indication that there's good agreement across investigators that some abilities decline over time, some remain stable. And it's when the slope gets more severe than what you see here that concern arises. Next slide. So not only can there be cognitive change over the decades, there can also be change in the brain over time. Typically, a way of studying this is to look at MRI scans and measure the volumes of certain brain structures. And here you can see some plots, and these are called spaghetti plots, and the lines attached by circles are individual patients over time. And you can see, for example, in the top two boxes, overall there's a slope across all patients with lower volume over the decades, and for individual patients you can see their change over time. And the second box on the right, hippocampus, is one of the key memory structures, and again you can see that there's some downward progression in the volume of that structure over the decades, which corresponds nicely with the change in memory with normal aging. So those are things that happen over time. Next slide. So normal cognition can really be a moving target depending on one's age. And so people, when they say, well, there's something wrong with my memory, or my memory's changing, they may be 100% right. And that's an accurate observation of change or decline over time, but that change or decline may be normal, or it could be abnormal for age. We don't know until we do some cognitive testing. That will help sort out the issue. Next slide. So that turns us to actual formal neuropsychological assessment. And I'll say a few words about the general approach to this for both people with epilepsy, people who are candidates for epilepsy surgery, and for individuals who come in with memory complaints with other medical conditions. Next slide. So the big picture is this, typically the evaluation will assess not only memory, but a variety of other cognitive domains, which are listed on the left. The intelligence, measures of language, such as the ability to name objects, fluency, ability to follow commands or comprehension, perceptual abilities, such as one's ability to match faces and be oriented spatially, memory, of course, executive function, which involves simple and complex attention, problem solving and planning abilities, processing speed, sensory motor abilities, and of course, emotional processes, depression, anxiety, as these can be related to test performances. So that's the big picture of, if you walk in and are to undergo a neuropsychological evaluation, you'll be taking some tests that assess those core cognitive domains that are listed on the left. You go to different centers, different practitioners may have different individual tests, but they'll generally be looking at performance across those specific cognitive domains. Next slide. And for epilepsy, what are the variables that can affect test performance? And you can think about this in terms of these three factors. On the left, we have what we call fixed factors. On the right, which we have remediable or perhaps treatable factors. And on the bottom are factors that are associated with the course of disease. So if someone with epilepsy comes in for an evaluation, there are a lot of things that we need to consider that we cannot change at all. They sort of come with the patient. And that's the nature of what caused the epilepsy for that particular person, which side of the brain the seizures start from, that'll be relevant to the test results, where specifically the seizures begin if they've been monitored, when did the seizures start, how long have they had it, what's their gender and overall intellectual capacity. So we'll want to know those things for sure. That'll help us interpret the test results that we do get. The course of disease is important as well. So across individuals with any particular seizure type, there'll be variations in a variety of factors, such as did they ever have an episode of status epilepticus or multiple episodes? Those can be harmful to cognition, and we want to know about that. Have they had a history of generalized tonic-clonic seizures, and can they estimate how many they might have had over the course of their life? That's a relevant factor. And have they ever sustained head injuries, either in general or in association with seizures? And the factors that are a little bit more remediable are the medications. Patients may come on a very aggressive polytherapy regime, which the specialists at our institution would then reduce to a smaller number and less cognitively adverse type. They'll work on seizure control. Cognition can improve with improved seizure control. Mood disorders, as I mentioned, can certainly affect performance, sleep disorders, and proximity of the last seizure to the assessment. So these are factors that can affect cognition in a variable fashion. Next slide. And also, depending on the type of epilepsy that the individual has, that'll also help us focus in on specific cognitive domains. So for temporal lobe epilepsy, which is the most common focal epilepsy, the site of onset of the seizures is deep in the temporal lobe, in the hippocampus or medial temporal lobe, and the core cognitive problem is memory function. If someone comes in with frontal lobe epilepsy, the seizures start in or around the frontal lobe, and they're more likely to impact executive functions. In children who have benign epilepsy with centrotemporal spikes, those seizures originate in or around the sylvian and Rolandic regions and more likely to affect language-related skills. Absence epilepsy, more likely to affect attention. So we may load up, so to speak, on particular tests depending on what we think the epilepsy syndrome that the particular patient has that is presenting to us. Next slide. And just to give you one example, how do we go about this? If we're going to assess memory, well, there's not a memory test. There are many, many memory tests. And so you might be read a word list consisting of 3 words, 10 words, 12 words, 15 or 16 words in length, and you might hear that word list 3 to 5 times. And we look at how well you can learn that over time. You might take a test where they read you short prose passages or even easy or hard pairs, and look at your ability to retain those things over time. So the point being, there are a variety of ways to assess memory function. The type of test you might take will vary with the practitioner, but they all do a reasonable job of getting to the issue of memory encoding, consolidation, and retrieval. Next slide. So let's look at some actual cognition and memory performance in adults and children with epilepsy. Next slide, please. So here we have, this is a study that was done here at the University of Wisconsin. We saw approximately 100 individuals who had temporal lobe epilepsy and 80 controls, and plotted our performances across various cognitive tests. Now, what you see here in orange are performances on memory tests. So the individuals had temporal lobe epilepsy. We'd expect to see memory problems in this particular cohort, and downgoing bars represent poor performance compared to controls. So we do see poor performance on the memory tests. But when you look across all the other tests, next slide, please. Oh, one more. There you go. Performance on average, and let me stress, on average across all these 100 patients, shows poor performance across most of the tests in the entire battery. And so this is interesting because it argues that it's not just memory. You need to look broader to see what's going on for any particular patient. And it's also colored perceptions of what the cognitive deficits are for any given syndrome. But as we see a large number of patients with temporal lobe epilepsy who come into the clinic for evaluation or for surgical consideration, there's actually a lot of individual variability that can be observed. Next slide. These average profiles are helpful because they provide a broad view of the disorder, but as I said, they're not always consistent with clinical experience. Some people are much better than that, some are much worse. And it was our sensation, it was our belief that there were subsets of patients hidden within these overall profiles. Next slide, please. And in fact, just hit one more button, please. We undertook a statistical procedure to try to identify subsets of patients by their cognitive profiles, if that makes sense. And in fact, within that overall cohort of 100 patients, there was a group, 47%, almost half, that had cognitive performance very similar to the controls. It's a little bit surprising, but it's a very good finding. It implies there's a spectrum of cognitive function in temporal lobe epilepsy with a good chunk of individuals with very normal performance. Next slide, or next button push, one more. Then there's a second group. There's a bit more of what we would expect to see. And these are individuals who have a prominent problem with memory, about 25% of this particular cohort. They're down on some of the other domains as well, but memory is the leading problem, and that's what we would expect to see classically in individuals who have temporal lobe epilepsy. This is a focal epilepsy syndrome. Next button push, and one more. And then there was a group, almost 30%, that is a very surprising group because this is a focal epilepsy syndrome. It affects the structures in and around the temporal lobe, where their cognition was grossly depressed, especially in memory, executive function, and speed. So buried within individuals with temporal lobe epilepsy, and my personal suspicion is this would be the case in any epilepsy, there are subgroups of individuals that can be identified who are either largely intact, show the expected cognitive issue, or show more problematic cognition. Next slide, please. And as you go from cluster 1 to cluster 3 that's intact to more impaired, the patients get a little bit older, they have a longer duration of epilepsy, take additional medications. And so we've also looked at imaging characteristics and a wide range of other factors. Next slide, please. And you can see we also followed the patients over time, 4 years later. So we tested them, the patients with temporal lobe epilepsy, and the controls came back 4 years later. And what you see here are plotted memory scores. So for the TLE group, in the orange are the baseline scores, and you can see the individual temporal lobe epilepsy do poor on the memory test. And then over the 4 years, performance drops a little bit in the temporal lobe epilepsy group, stays stable to improves a bit in the controls. So over this 4-year interval, there is a bit of decline in memory performance over 4 years. Next slide, please. In terms of how fast tasks can be completed, such as a memory task or a motor task, again, looking at the orange, you can see the epilepsy patients are slower compared to the controls at baseline. They get a little bit slower over the 4 years, whereas the controls stay stable. So these are not huge changes, but they are discernible and measurable changes that take place over 4 years. Next slide, please. And go ahead and hit the next button. We spent a fair amount of time trying to figure out what predicts stability over 4 years versus the decline. And actually, only 25% of the patients showed some decline over time. 75% stayed very stable. So then the question is what predicts a rocky or cognitive course over 4 years? And what predicted cognitive decline were measurable abnormalities in MRIs, lower baseline IQ, a longer duration of epilepsy, increasing chronological age, fewer years of education, earlier age of onset of epilepsy, more AEDs, poor seizure frequency. So the point of all this is that decline can happen. It occurs in a minority of patients. It is possible to identify the factors responsible for that, some of which are treatable, such as seizure frequency and the number of AEDs, some of which are not, such as chronological age. Next slide. So these participants are in their mid-40s on average, and so the issue is what happens over time, what happens 10, 15 years later. There's now a lot more interest in this in epilepsy. There was not that much interest 10 years ago, but as aging of the world population has become a bigger concern, it's become a concern for epilepsy as well. So what does the cognitive aging process look like for individuals who have had lifetime epilepsy or develop epilepsy later in life? Next slide. And this has been a very difficult issue, and there is a hint, some data on this, and it comes from a collaborative study in Finland, which is contains a very interesting cohort of patients I'll tell you about. Next slide, please. So this is Professor Matti Sillanpää, and early in his child neurology career, he was a child neurologist. He was working towards a PhD, and he decided to gather a population-based cohort of children with epilepsy. Everyone in a particular region who had epilepsy who was under age 16. And he also added population-based controls. And he got his PhD in 1973, and he has followed this cohort of participants, childhood onset epilepsy and controls, over the years and over the decades. Next slide. So like his participants, Dr. Sillanpää's gotten older as well, and the cohort's really interesting. Their age at initial assessment was about 5 years, and they are currently 57 years old. And he's followed these folks over his entire career and their lives. And at various points over time, he would derive neurological, health, social information. How's their epilepsy history? Have they remitted? They continue to have seizures? What's their work history? How are they doing in life? It's been a remarkable series of studies. Next slide, please. So we've collaborated with Professor Sillanpää and his group over the past several years, and he was actually able to recruit his participants and have them come to Turku for a series of tests. And they came in and took cognitive testing. They underwent an MRI. They underwent PET imaging, including amyloid, which is accelerated aging biomarker, EEG, in a clinical interview. Next slide, please. And here's the results in regards to memory. So this is a memory task, and this is really quite interesting. This is a memory test where 15 words are read in 15 seconds, and the subject is asked to just say as many words as they can recall in any order. And this is done again and again and again and again. It's done 5 times. And so you can get a learning curve over time. You just plot the number of words recalled across trials. And the heavy dark line are the healthy controls, and they show what would be expected. They learn over trials. They get up to a little over 10 words, start about 5. So they've doubled the number of words they can recall across the 5 trials. And in the heavy dots, the big dots, are the patients with epilepsy overall, showing 48 people with epilepsy. And they're significantly below the controls in their performance. But when you break the epilepsy participants, excuse me, up into 2 groups, there's a huge difference. If you look at those whose epilepsy remitted, that's the dashed line, they are just like the controls. There's no difference compared to the controls. So for some reason, their epilepsy stopped. They were able to be removed from the medications, and their memory performance at age 57 is just like the controls, which is a very favorable finding. Those individuals who continue to have seizures, and that's a small dotted line at the bottom, you can see that they continued to struggle. They struggled with memory. The learning curve is pretty flat, and their memory function is abnormal for their chronological age. So whether people remit or don't remit is a huge determinant of memory performance over the long haul. And again, remember that their seizures started at age 5, and they're now essentially 57. Next slide. And the other interesting finding was that this biomarker called beta amyloid requires a specific scan to measure. And the presence of this biomarker was increased in the childhood onset cohort. There was no difference between those who remitted and those whose epilepsy continued. And this is of some concern, and it's the first study of its type. We're currently in the process of having people come back 5 to 6 years later, where we can see, we don't know when this was laid down, if this is something that has been present for a long time, or if it's something that marks accelerated aging. And by coming back 5 to 6 years later, we can see if this changes, is increasing, or just remains stable over time. So the prospective results will be clearly important, and we'll see what memory looks like as well. So that's a very interesting and important study that's going on, conducted by Dr. Sillenpau's group. Next slide. So what to do about all this, right? That's probably the thing that you're asking. Next slide. Well, this has not come from epilepsy. It's come from general aging, the general aging literature, and it's increasingly reported in the preclinical Alzheimer's disease literature. So it's now known in that literature, and been shown in very large cohort studies involving thousands of patients and multiple studies, that a variety of lifestyle environmental factors can affect cognition. Education, occupation, alcohol and nicotine consumption, the degree of stress that someone might be subjected to over the course of their lifetime, the degree to which they participate in cognitive and leisure activities, the degree to which they get physical exercise, the presence and severity of obesity and diet issues, and health status. What's the number of other medical comorbidities that may be present? Next slide. And we do know that there are people with epilepsy are subjected to a lot of difficulties through the course of their life. This comes from the Centers for Disease Control behavioral risk surveillance studies and other studies. And they have demonstrated through these population-based surveys that in general, individuals who report epilepsy have experienced more unemployment and underemployment, have lower income, have been subjected to less educational progress, have had fewer marriages and may have more limited social networks, may be more physically, and may experience more physically and mentally unhealthy days, and are more likely to live alone. So these are all factors that would work against cognitive protection. Next slide. And in fact, individuals with epilepsy, shown here compared to those who have a history of epilepsy, and those with active epilepsy compared to those without epilepsy, show fewer healthy days. And the work from the CDC has been just critically important in demonstrating these sorts of difficulties. Next slide. So major tasks, and this is true for individuals without epilepsy, it's true for the general aging population, it's true for those who have a family history of Alzheimer's disease, who are at risk for neurodegenerative disorders of that type for any reason. There's a big push now to take better care of health, to eat a healthy diet, to be physically active, keep your mind active, stay connected. All the things your mother told you are actually true. Next slide. And the CDC has been very prominent in bringing this home for people with epilepsy. So the CDC Managing Epilepsy Well Network and the Epilepsy Foundation works very closely with the CDC, has worked on a wide variety of very important problems and issues for people with epilepsy. And their self-network management programs can help with issues related to mental health, memory problems, dealing with stress, managing epilepsy care, and health and well-being. So if you're not aware of this, what you want to do is you want to open up that link that's shown there. That'll take you to the Managing Epilepsy Well series of studies. You can learn about those and get more information and participate in those programs. So take a close look at that. Go to the CD website otherwise, but the ManagingEpilepsyWell.org network link is particularly important. Next slide. And in particular, in regards to memory problem, there's a specific program called Hopscotch. And this is a memory program for people with epilepsy. Over half of people with seizures experience memory problems and feel that seizures interfere with memory. And the Hopscotch program has been going on for several years now. It's very effective. It's the principal investigator is Dr. Jobst at Dartmouth Hitchcock Medical Center, New Hampshire. And again, there's a website that you can log on to find out more about that and to participate, or you can probably contact the Epilepsy Foundation. They'd be happy to refer you to that program. So there are things you can do in general and things you can do in particular if you have epilepsy. Next slide. And there's a lot of information about how to have healthy cognitive and brain aging through a variety of sources, including the National Institute of Aging, the CDC, National Institute of Neurological Disorders and Stroke, ARP, and the Institute of Medicine. So all you need to do is get on their websites, and quite quickly you'll be able to get to the pertinent sections that will talk about healthy cognitive and brain aging. This is very prominent now in the Alzheimer's disease world. And so the information that they're deriving is pertinent not only for Alzheimer's disease, but for the general population. Next slide. And I'll conclude with a few words about children and cognition. Next slide. So one of the major developments that's happened over the probably the last 10 to 15 years, the belief always has been in the past that epilepsy will cause progressive cognitive and behavioral changes. That was sort of the predominant view for decades. And in the recent past, there have been some studies that have begun to study individuals with epilepsy right at the beginning of their epilepsy course, sometimes even before medications are given. Next slide. And this was sort of the core study. And this was done in the Netherlands by Oostrom and collaborators. And they tested a cohort of children with epilepsy and controls right after they were diagnosed with epilepsy and before they took any medications whatsoever. And I know everyone is concerned about the effects of medications on cognition and memory and so on. This was done before any treatment. Downgoing bars represent poor performance compared to the controls. And you can see right at the outset, there were more behavioral issues, attention issues, slower reaction time, learning, difficulties and a trend towards poor academic performance, like reading, spelling, and math tests compared to controls. So very early in the course, these problems are evident, and it's a great time to jump on them. Next slide. And especially important was that some of these difficulties were present even before the first recognized seizure. If you went back and looked at their history, which these investigators did, they found that 51% of the group with newly diagnosed epilepsy needed some special school assistance in advance of their first recognized seizure and diagnosis, compared to 27% of the control. So they said the school career was already at risk to some degree. Next slide. And we began our study about 16 years ago. We see children aged 8 to 18 with new onset epilepsy. We test them in the first 12 months of their diagnosis. And you can see our results compared to the Dutch cohort. And so what they reported and found is exactly what we found. That right at the very beginning, there are some problems that are evident in objectively tested cognition. There are school problems that were evident before, and there were behavioral problems that are present at the time of diagnosis and were present prior to the diagnosis of epilepsy in the first recognized seizure. Next slide. The good news is that if you look at development, and we've studied the children, this shows at baseline, 2 years after baseline, and 5 years after baseline. This is, for example, IQ. These are raw scores. These aren't IQ scores. I want to make that clear on the left side. Those are raw scores. And what you can see at time 1, that's baseline, the children with epilepsy do a little bit lower than the controls. They fall in the low average range, but they're significantly below the controls. But over 5 years, and in the presence of seizures and medications, they develop at the same rate. They're parallel lines, essentially. And we find this for just about every cognitive function that we've looked at. We find this to be the case for behavior, where the behavioral scores might be different at the beginning of baseline, but they don't progress. They're stable and parallel lines over time. So this offset that you see initially is simply maintained over at least 5 years. So we've done this 5 years, and we're following the cohort up at longer times, 10 years, and we have plans to study them over as long as out to 15 years. Next slide, please. And medications is a very complicated topic. I think this slide is a nice summary. There's been a lot of interest in the effects of various medications on cognition and motor skills, memory, mood. This is just a brief synopsis, and this can be a point of discussion with your clinic nurse or physician if you think there are some cognitive difficulties or mood issues and a possible relationship to those sorts of problems. Next slide, please. So all this work is due to a large collaborative group, and just want to make that clear. It's also been supported by NINDS, the National Institutes of Health, as well as by CURE, and the dedicated work. All these individuals are very committed to understanding epilepsy and improving the quality of life for people with epilepsy.
So I'd like to take this opportunity first to thank Dr. Herman for a really wonderful review of epilepsy and cognition. I'd also like to thank everyone who's joined us for their interest and attention. We encourage everyone to take action and bring the information that you've learned today back to your healthcare team and ask the questions you need to better understand your epilepsy, the treatment of your epilepsy, and the impact it may have on cognition, and what you can do to maintain the best possible cognitive health. The Epilepsy Foundation, of course, is here to help as best we can, and we also encourage you to continue to reach out to the Foundation for additional learning on epilepsy.com and by calling into our 24/7 helpline. You can also reach out to your local Epilepsy Foundation office, who can provide you with information and support, and also to help link you to those Managing Epilepsy Well programs that Dr. Herman referenced.